Alok from Chitrakoot is going to speak on Mantoux and QuantiFERON, truths and untruths. I think this is a topic that everyone wants to hear in any latest meeting. Go ahead.
Can I have my slides, please? Yeah, thank you. So good morning all, and thank you for this opportunity. The topic that was given to me was Mantoux and EGRA, truths and untruths, and I'll try to do justice with the topic given. I have no financial disclosure for this talk. I'll start with these three case scenarios. Case one, you see multifocal healed scars, and you have an active retinitis patch with some vasculitis. Now this patient has a positive TB gold. The second patient, you can see multifocal lesions in the retina, again retinitis, retinochoroiditis you can say, with dense vitritis, a pan-uveitis-like case, and you have on CT chest, you have what is known as buttery appearance, which is very suggestive of pulmonary TB. And the third case, you have this peripheral granuloma and a positive Mantoux test. So in which of these scenarios you would start ATT? And I think majority and even the test physicians will agree with the second case that they would put this patient on ATT in spite of a negative Mantoux. While in the case number 3, you would all agree that we would start patients on ATT. And in case number 1, I think many of you would even not advise the patient a Mantoux test. So with this background, ocular TB has always been a challenge for diagnosis, and the definitive diagnosis, of course, is based on isolation of the bug or its DNA from the ocular fluids. However, these tests, microbiological tests, are very difficult and they lack sensitivity because of the possible bacillary nature of the disease as well as the difficulty in sampling ocular tissues. So majority of us, we make a presumptive diagnosis of TB based on the consistent features of ocular TB. This is very important, and on a positive immunological or radiological test. So coming to immunological tests, these are tests which measure the cell-mediated response to TB antigens, and we have two tests, Mantoux, which measures the delayed hypersensitivity to the TB antigen, and interferon gamma release assay, as the name itself suggests, it measures the interferon gamma response to sensitized T cells. Now, both these tests are unable to differentiate the latent TB infections from active TB. Of course, latent TB infections now is still another area of contention. Now, Mantoux, as you all know, is one of the oldest tests which is still relevant in clinical practice. We do it daily, almost daily, and it measures the response to intradermal injections of protein, a very crude protein antigen derived from cultures of MTB. Now, the test has to be interpreted based on in which patients we are doing it. So it has, the test positive results have been categorized into different levels. So if you have an immunocompromised patient, even a test which is 5 millimeter positive is taken as positive. While in patients who are at high risk of developing TB, you have a test which is 10 millimeter is also positive. But in endemic areas like in India, we would rather believe a 15 millimeter or more enduration, which is to be positive, so that we don't unnecessarily treat a lot of patients with ATT. Now, there are a lot of situations where these tests can be negative because of the technique and interpretation of the test, as well as a lot of biological causes which can lead to a negative outcome in these tests, even if the patient has ocular TB. And of course, these tests are affected by BCG vaccination, although this is very rare, and after 10 years of vaccination, almost none of this can come positive because of vaccination. Now, other non-tubercular microbacterium can also give a positive test or false positive test, TST. So these things have to be kept in mind. Coming to EGRA, there are two types of tests available, and these measure one measures the gamma release by the sensitized T cells, the other counts the number of sensitized T cells. These are the two difference, and these are the various antigens that are used for this test. Now, a positive results is as shown on the slide, But the advantage of this test over TST is that it seems to be more specific for Mycobacterium TB, as it is unaffected by BCG or non-Mycobacterium TB. And the patient requires only a single visit. However, the disadvantage is, especially in low-resource countries like India, it can be expensive, you need lab equipments, and it is time and temperature sensitive. Also, there are reports that it could be, the sensitivity could be lower as against TST in TB endemic countries. Now, this is a very important table from a very important article on ocular tuberculosis, which was published way back in 2009 by Professor Amod sir. And what is important when you when you do interpretation of this test is the clinical presentation of the patient. So these tests have to be interpreted in context with what clinical picture is there in the patient. As you can see, that the pre-test probability in an endemic country is almost the same, but the likelihood ratio will depend on what is the clinical presentation. And if you see vasculitis with choroiditis, subregions-like choroiditis, or broad-based posterior synechia, and you can see that the likelihood ratio is quite high. And if you have these symptoms, then the post-test probability is very high that the test is positive. So always you have to do interpretation based in context with the clinical presentation and never alone. So to summarize, TST and IGRA most commonly used tests to diagnose ocular tuberculosis. Both the tests have equal sensitivity for diagnosis of latent TB. IGRA probably is more specific than TST. Neither test can differentiate active infections from latent infections. Negative tests, as I had shown in the second case, do not rule out ocular TB, and interpretation of tests should be done in context of prevalence of TB and consistent clinical picture. That is very important. So I thank you, and I thank Professor Amod, who has always been guiding me with all my work. And I think it is only because of me I have this position in the state. Thank you.